big important contraindications for ultrasound? Pregnancy. Good. What did you say? Over the growth plates. Good. Any active bleeding, history of hemophilia. Yep. Pacemaker. Fever, because fever indicates what? Infection. We don't want to grow an infection. Pacemaker, we said malignancy. Yep, that's a big one. We did blood clots. Oh, you were. That's a great trick where after someone gives an, you're like, oh, that's the one I have. Great trick.
That was great to say.
You got an even better excuse in your back pocket. Like, oh no, that was my answer. I just couldn't. Thrombophlebitis, yeah, you got it. Over hearts, ganglia, nerve root. I'm sorry, the stellate. What was the stellate again? What was? It's near the nerve root. I thought I remembered it being near the nerve root.
It basically was a type of nerve root, I think.
All right. Any important precautions?
Not over bony prominences.
Not over bony prominences, and the big reason for that is what?
Just kind of the depth of ultrasound, because I know with Onic, it's the depth it goes to is at least 5 centimeters or.
Yep. So what's going to happen with those bony prominences is that the sound waves are actually going to bounce off of the harder structure of bone, and then the tissue in between the ultrasound head and the bone, that tissue is going to become overheated because all of the sound waves are being concentrated to that small area. Good. Any others?
Keep the thing moving.
Keep the ultrasound head moving, or else we develop an unstable cavitation. So that wouldn't be good. Cause tissue destruction. Good. Anything else? Any other major precautions? Not for ultrasound.
Oh yeah.
You're thinking of what? Laser, yeah. Yep. Metal plastic implants, the other precaution. All right. What was my ultrasound decision making? My first question I asked myself is what?
Non-thermal.
Do I want thermal or non-thermal? And that would mean the injury is either chronic or acute. Okay, good. So I either want the thermal effects or I don't want the thermal effects. My next question was what? Depth. And the depth, what parameters am I going to change? The megahertz, which is also the frequency that we're changing. And if it's superficial, I want what? 3.3, I think is what our machines go to. And if I want deeper, I want 1 megahertz. Good. So that's my second question. What's another question I asked?
Area.
Treatment area. Good. And if I'm on the deep settings, what's the maximum treatment area?
4 times
2 times effective radiating area, which that area is slightly smaller than the ultrasound head. All right. And then if it's non-thermal effect, what do it's less than 4 times effective radiating area. Now how much less, I don't know. So if you're at 4 times the ERA, it's too big. All right, and then what's the next question? Oh, and give me time, since we were trying to figure out treatment area. What time? 5 times your treatment area, ERA. So, we could be really focal if we only wanted 1 time. Okay, fine. I just have to keep it moving in that small area. So yeah, it's 5 times per ERA. So if I've got 2 times my effective rating area, then it's 10-minute treatment. If I am at that slightly under 4 times, I'm there for a long time. I'm not doing that. All right, and then the last thing was the intensity, right? So what are my intensity parameters if I'm on the thermal effect? It's continuous. Yep. There's a little bit more details I need from that. So if I'm more superficial, I have to cut the intensity down because then I'm overheating the tissues too much. So it's 0.5 watts per centimeter squared if it's thermal and superficial. And then if I'm deep, then what do I get to do? To 1 to 1.5 is what our textbook says. Some textbooks do say up to 2 would be okay. The machines themselves can go up to 3 watts per centimeter square. I have a hard time thinking of why I would do that. You know, if it's not working, you say, oh, turn up more. Maybe you're just not, maybe it's just the ultrasound, it's not the actual settings. All right, and then if I'm on the non-thermal settings, 0.8 to 1.0, regardless of depth, doesn't matter. All right, good. Anything else with that? I think that's everything. All right, next up, I wanted to just talk about phonophoresis and then ultrasound underwater. So phonophoresis is applying ultrasound with a topical drug to facilitate the transdermal delivery of the drug. So we're driving medication into the skin with ultrasound power. So that's pretty nice. So better than probably an injection of some kind. Lot of different results, mixed results, depending on a lot of different variables. Really, it's the tissue of our patients is what's going to dictate the success of that. There's another way in physical therapy we can deliver medication with modality called iontophoresis. That uses electricity. We'll talk about that in a little bit. Most of the research says there's potentially more benefit at the deeper settings, so the more superficial. Okay. The medicine is introduced as the coupler instead of our typical gel. It's medicine in a liquid or gel type substance. The most common is 10% hydrocortisone cream. There are other ones to it. So great thing about it, little systemic effect, doesn't have to pass through, you know, we don't have gastric irritation for us. So if we do have acute pain, we can take care of some acute pain at a focal level with medications. Medications are going to interrupt that pain cycle more at the cellular level. The problem with even NSAIDs, the big problem is what? Give me more. You said blood thinning is the big problem with NSAIDs. So it can be, but then it also can create GI discomfort, including ulcers. And then if we combine that with a bleeding problem, then we have a big problem. So, yep. We can treat a fairly large area with it. You know, if we do an injection, that injection is really focal. Here we get a little bit bigger of a treatment area, no needles, great. Tendinitis, bursitis are really the big things for the unrelenting tendinitis and bursitis. Same contraindications and precautions as ultrasounds, except we also have to consider drug interactions. Are we taking in that same drug with, oral medication or now potentially overloading the system. The exact treatment's a little undefined for us, so we like to be exact. We have less ability to be exact with that. And then we also, because we're introducing drugs, now we also have to consider drug allergies, which the patient might not know they have when they're doing this. So that can be a potential problem. So theoretically, ultrasound drives the medication in the skin, helps be absorbed by vasodilation of the capillaries and the increased permeability of those cells. Some questions of the effectiveness. The research is a little unclear. So the common medications, hydrocortisone powder in gel, the 10% hydrocortisone in gel is most common. We also have Lidex, Dexto, and Lido, Indo. In your textbook, we have different medications and their dosage parameters. I don't expect you to know that by heart or anything like that, but it is important that when you do have the patient with this, you would be well aware of the parameters and you would be teaming up with the physical therapist to make sure that, yes, these are all the settings, this is exactly how we do it. Most of the time, the other thing is it is a prescribed medication for the patient. So the patient has to pick it up at the pharmacy, then bring it to the clinic. And then there's some questions. Does the patient bring it back and forth each day? Does it live at the clinic? Like there's some of that questions for it. It basically is just almost like a chalky version of the ultrasound gel you already look at. Most of the time I see it's a little bit more watery than the gel that we have is a little bit thicker substance, and it can leave like a chalky residue on it, but it's basically the same thing.
That's from the PTs prescribing for them, or is that like from their primary?
It's from their primary doc prescribes it. We don't
Okay.
actually get to
That's what I figured.
prescribe medication, but I could call the doc and say, hey, doc,
Is what
I'm stuck with this patient. I think we got to try this. And most of the time doctors say, yeah, sure, great. Because while we have to make sure that the patient doesn't have any drug interactions, which can be complicated, luckily we get to ask the pharmacist, hey, what do you think of this? And they're the experts on that. And we also get to talk to their primary cares about other drug interactions or allergies that we have to be concerned with. So it's in general, it's pretty safe delivery of medication for us. But yeah, that's the kind of runaround. Call the doc prescribes it, patient has to then go get it and then bring it to us, and then we start using it from there. So
All of them pretty much just manage pain.
most, yeah, pain or inflammation, depending on what the medication is.
is it very common?
Very common, I would say no. I probably used it once every other month or so, 5 or 6 times a year. You might have so it's not rare, but it's not common. Anybody have a word for not rare, but not common? I don't know what that.
So what makes you thought like ultrasound, like they don't prescribe?
So the patients that would fit this, if I'm the one leading the charge, it's the ones that I'm lost on. I can't break through this for some reason. We've checked all the other boxes. We've tried all their treatments. We know it's not something else. We know it's not cancer causing shoulder pain. Like we've crossed out everything else, and it's just this thing is just not getting better. That's the time I would say, well, we can try now medication with this stuff. That's if I were to lead the charge. But a lot of the times the patients will come into us and say, hey, my doc gave me this. And also, I think I'm trying to think, most of the time the patients will come in with it on their first visit. And I believe in general, I'm trying to think in my experience, they failed physical therapy somewhere else, went back to their doc, and the doc said, well, you can go somewhere else and we'll also try this. Like, so I'm like kind of the second or third PT that they've seen for their same problem. So their doc's giving them a little extra something. They're now going to a new practitioner because they've already failed somewhere else. So I don't. I think maybe once in my career, I've led the charge of we need to try something else. We can try this. I think the rest of the time the patients come to us with it. Another thing we can do is we can do ultrasound underwater. Really good for irregular shaped anatomy, hands and feet, potentially wounds as well. The heatingness effectiveness is reduced when water is performed underwater. Intensity of the ultrasound should be increased by at least 50% when performing underwater, because we're losing a lot of the energy in the water medium itself. So we don't actually come in contact with the patient. We hold a transducer 1 to 2 inches away from that patient's surface, but we're still constantly moving it. That's still a rule for us. So that's a fun thing that we can do. I've never had to do it, but you know, hands and feet, irregular shapes, really bony, super fit, like, you know, that would be another concern for hands and feet. So here's something we could do. I've never had to do this one. But, you know, just to make sure we're on the same page, like, just like with diathermy, I'm teaching you the bare bones of what you need for diathermy, what I think you'll see clinically the most, what I think will be on the licensure exam the most. And it's up to you to, if it's available to, you will eventually learn more about whatever that modality is because it's available to you. So other applications for ultrasound, we can do it over wounds. We can do it in water with wounds, or there are ultrasound coupling sheets where we get to put a sheet over the wound that protects our equipment from their wound, and then we can do an ultrasound with that. I've never seen that happen before. But again, if you're interested in wound care, I think you can make a good career and a well-paid career if you were to be a wound care expert in physical therapy as a physical therapist assistant. Because I mean, how many modalities have we talked about with that have the potential to be used for wound care already? Ultrasound, diathermy, what else? Anything else? What? Whirlpool. Yep. Anything else? Potentially laser. We even talked about hot and cold, and maybe we don't apply it directly over the wound, but if we apply it distal to the wound, we can generate blood flow through the wound. So I think there's a lot of things we can do with modalities for wound care that can be really interesting. Again, if you guys wanted a long and profitable career, and if you liked wounds, yeah, you could definitely do that. There are also ultrasound for bone fractures. I've never seen one of these units. I've never heard of one of these units. I've had other bone stimulators that my patients use, but of special very low dose bone stimulation units, 1.5 megahertz, 25% duty cycle, 0.15 watts per centimeter squared. So really low power. Yeah, I've never seen one of those, but it exists. Yeah, maybe again in 10 years at some point somebody's gonna email me and say, Josh, you'll never guess.
Absolutely wrong.
It's trying to provide the same therapeutic effects to heal that fracture. You would never do this right off the bat. You never say like, oh, you got a fracture, let's try this ultrasound. It's you've had this fracture for 6 weeks and it's not healing. Like, we've got to do something. It's the panic mode for orthos. Like, I can't. They probably email each other and say, you'll never guess what I had to do. And prescribe a bone ultrasound to, yeah, I don't think it happens an awful lot.
So other than wound, why would you use ultrasound in water?
Just the irregular, why would you use ultrasound in water? Just the irregular shape of the hands. So if we had a bunch of finger fractures that we thought, heel finger fractures, they're just not moving, they're stuck, and they need to generate some. I think ultrasound is going to be beneficial for that. That could be a trigger finger. If you ever heard tenosynovitis, of the long finger flexors or extensors, that could happen. So there are some conditions that you could potentially use it for.
Do
Yeah,
we treat like everything that's merged or still just like?
It's the same treatment area that would apply without underwater. 2 times effective radiating area for the thermal effect, 4 times for the non-thermal effect. So, yeah.
Does the transducer part just stay above the water, or does that actually go under?
It's
the water?
submerged. It's in the water.
Okay.
Yeah. Yep.
So when it says like the intensity of the ultrasound should be increased by at least 50%, do we go off from the numbers from as if it wasn't?
Yeah, yep.
So.
Double it. Yeah. Yep. No, yeah, not double, times 0.5. You're right. Yeah. Yeah. We're also going to talk about ultrasound combination later in the semester, when now we're using an electrical current through the ultrasound head. So that's kind of fun. We'll play with that. Good for muscle spasms. We got some rules for that we'll cover later. All right, any questions on phonophoresis or ultrasound underwater? Those are the big things. All right.